So I'd like to start off by introducing those that are here with us today. So to my right, immediate right, we have Dr. Andrew Hunt, who is the Assistant Dean of Distributed Medical Education with the Faculty of Memorial University, or Faculty of Medicine at Memorial University. Second, next to Andrew, is Sandra Badcock, who is the coordinator of, oh my goodness, I can't read my handwriting here this morning, of Institutionalized Medical Education? Distributed Medical, sorry, that is a D. Distributed Medical Education for the Faculty of Medicine. They're going to tolerate me this morning because you all know I've been at this podium now for how many days and trying to keep things going. Third, and on my right and your left, is also Dan Fitzgerald, Manager of Contract Physicians with Medical Services Division of Health and Community Services. And I'm also very proud to introduce Dr. Margaret Steele. Dr. Steele is the Dean of the Faculty of Medicine, and she is on my left and to your right. And we'll hear from Dr. Steele later as well. I would also be remiss if I didn't acknowledge one of our former colleagues from the former Department of Municipal Affairs, Paul Tucker, who is currently the COO of the Faculty of Medicine. Paul, of course, as you know, held the position of Municipal Finance at MA for quite some time. So welcome back to the floor, Paul. It's great to have you with us again. So today's presentation is about engaging our municipalities in physician recruitment and retention. So I'm going to take you through a number of slides, and then my colleagues here are going to take you through a number of slides and some information, and then we're going to hear from Dr. Steele, and then we're going to open up the floor to questions, and we have some important questions we want to pose to you. Before I go any further, I would like to read our land acknowledgement. We acknowledge the province of Newfoundland and Labrador as the ancestral homelands of many diverse populations of Indigenous groups, and we acknowledge with respect the histories and cultures of the Beothuk, Mi'kmaq, Mi'kmaq, Innu, and Inuit of the province. So in terms of how we're going to run through our session today, it is key that we get your feedback. And we'll certainly elaborate on that later and how we're going to do it. But we're going to touch on a physician recruitment and retention workshop that was completed in June 2021. We're going to talk about the recommendations that came from that workshop. There are 10 of those. We're going to talk about committee work and what was established here to advance this file and this issue on your behalf. And then we're going to talk about community engagement. And effectively, we're going to move forward and ask you questions and seek your opinion on a number of the key topics. So to keep things moving, I want to hand it over to Dr. Hunt, who's going to talk about the physician recruitment and retention workshop. So Dr. Hunt. Of course, that canister had to be empty, didn't it? Okay, Andrew, over to you.
Great. Good morning. Thank you, Mr. Power, for that kind introduction. So, as a reminder, I'm Dr. Andrew Hunt. I'm the Assistant Dean of Distributed Medical Education with the Faculty of Medicine at Memorial University. But I'm also a family doctor in Toolkit, fine town of Toolkit in this province. And I think that's important to illustrate here as well. I'm not up here tooting my own horn about that, but certainly I think that's an example of successful recruitment and retention in this province. I'm a family doctor in my hometown. I was actually born in Toolkit, raised in Toolkit, and I've been working there now for the last 10 years. I did my medical training with Memorial University, much of which actually involved rotations and experiences in the rural environments and rural sites of this great province. And it's because of that exposure that I was enticed to go back to my hometown to work, amongst other factors, obviously. And I'm just one of 4 physicians who work in that town who are actually rural Newfoundlanders. 2 others actually are from Toolkit as well. So I think that is a great example of where recruitment and retention is really done itself great justice, and I think it's turned out for the better. And I think we can learn from that example and apply that to other sites. I'm not saying that Toolkit's the only place in this province where we've had that success. Many other sites as well. But we see oftentimes there's lots of turnover with physicians, and some sites have lost physicians and have not been replaced, and so they're struggling. So I think just by utilizing that example, I think we can look at how we have been successful in some places and how we can apply that to others to make sure that we have a strong future in this province for physician services. So guys, I'm honored to be here. This is absolutely amazing. I'm so thankful that you were able to give us this opportunity to come and talk to you about this very, very important topic. I'm just as excited to see you all here, knowing that you're here, that you're willing to participate, to listen, to be a part of this great initiative is extremely important to me as well, because without you, we're unable to be successful. I think we can optimize our efforts knowing that you are all on board as our partner as well. So that's extremely exciting for me this morning as well, to be here in front of you all, knowing that we're all looking towards the same goals. So thank you. So I'm sure you've heard and seen it all in the media, 98,000, 99,000 people in this province with no primary care provider, and that can refer to a family physician or a nurse practitioner. And that also includes our multidisciplinary approach to medical care in this province. We're short on paramedics, nurses, allied health workers, etc. So it is a big, big problem. So we need a solution to this, a direction to help us find answers to these problems. And of course, it isn't a simple answer or a simple solution. It's multifaceted, and again, it includes your input, which is extremely important, as is the input of the other stakeholders in the province as well. So this issue obviously was identified quite a while ago, and members from the Department of Health, the Deputy Minister, approached Dr. Steele and her team and requested that we formulate a recruitment and retention committee that was designed to address these issues that we're facing and the challenges that we're facing with recruitment and retention. So Dr. Steele and her team formulated this committee, led by Dr. Scott Moffat and Vernon Curran, amongst others. And we engaged many within the Faculty of Medicine and around our province to design a recruitment and retention workshop. So what we did was survey many stakeholders across this province and included what we felt were a good representation of those that should be engaged in this initiative. Just move along the slide here. So the idea behind this was to ensure that we encompassed and that we included as many people as we felt were very important in the recruitment and retention efforts in this province. So as you can see on the slides there, what we did is we formulated a group that was made up of members from the regional health authorities, so there was representation from all of the regional health authorities in this province. There were representatives from the Government of Newfoundland and Labrador and Department of Health and Community Services, and you'll hear from Mr. Fitzgerald in a few moments. Importantly, there was representation from our communities, our municipal groups, extremely important there as well. Memorial University was well represented from the Faculty of Medicine perspective, from staff, faculty members, and learners as well. Students, medical students, residents, etc. were all a part of this workshop. And also we had members from our regulatory body, or the College of Physicians and Surgeons in Newfoundland and Labrador, which is our licensing body, and individuals and groups that are involved with quality assurance, quality improvement in our province, as well as far as physician care goes. And we also had representatives from the Newfoundland and Labrador Medical Association, which I guess for lack of a better term is considered unofficially the physician union, the physician voice. So we sent out information around the desire to do a physician recruitment and retention workshop with this large group. We sent out invites and we sent out a survey that was developed from research that had been performed by many of our excellent faculty and others across the country as well. Dr. Shabnam Asghari and others, Dr. Steele herself, our former dean, Dr. Rourke, have done excellent work in recruitment and retention research in our province over the last number of years. And we use that literature, that research, to help devise the types of survey questions that we would ask everyone in this group. So that set the framework for designing this workshop. So in June, get it there. So in June of this year, we held a one-day session where we had about 80 individuals, representatives of those groups that I just mentioned, who all came together virtually, obviously, because of the constraints of COVID. We had large and small group sessions. And based on the survey results, we were able to narrow down our topics to 4 main themes. So firstly, we talked about opportunities, challenges, and risks for recruitment and retention in our province. That included components of medical training, personal attributes, and the communities themselves and how people feel incorporated in the communities. A second topic was the compensation model redesign, and I'm not sure how aware of physician remuneration models you are in this province, but they are variable. But for the majority of our rural physicians, it's via fee-for-service type of model where physicians get paid based on the number of patients that they see. So essentially what it boils down to is there were some concerns regarding remuneration for quantity versus quality, and many felt that this could be interpreted as a deterrent to assist with recruitment and retention in our rural areas. So it was a topic that certainly had significant attention. The last 2 topics were surrounding recruitment, were surrounding how to better recruit physicians, and secondly, similarly but different, how to retain physicians. And again, we looked at components from training in the medical school, practice environment, and again, the roles of our communities and how people feel incorporated when they go out on rotations, how they feel that they're a part of the community, for instance. And that's really where you guys come in and why we're here. So from that workshop, we developed a report of all the information that was gathered and all the information from the survey, all the feedback that we had from everyone. Not everyone could attend, but they were certainly invited to provide feedback, and certainly they did. There was a lot of response. And that shows us that there's a lot of interest in this topic, and really a need is there. So there were 10 recommendations that were developed with 7 collaborative partners. And as you can see, these partners are extremely important in ensuring the implementation of these 10 recommendations. Now, these recommendations looked at things, as I mentioned, like physician remuneration, looked at medical school training, admissions, things like that. Each one of the recommendations was assigned to one of the organizational partners to ensure its implementation. So, for example, recommendation number 6 referred to how we could increase the number of seats at our admissions process for rural students. So, students identifying as having rural backgrounds, and how we can increase the number that are admitted to our medical school. And of course, the Faculty of Medicine at Memorial University was tasked at ensuring the implementation of this recommendation. But it's recommendation number 10 that is really important to the members in this room today. And that's essentially, again, why we're here, to talk about how community engagement is important in physician recruitment and retention. So I'll read it out, if I can see it there. Brad, you've made the screen a little bit far away. I guess maybe my age is starting to show through too, and not as clear as it once was. But what it says is engage communities in recruitment and retention processes focused in marketing, communication, and making newcomers feel welcome. So I think that's extremely important in our recruitment and retention efforts in this province. And out of that, we struck another committee that includes members on this stage, actually, and this is who you're hearing from today, about developing a toolkit that involves communities, municipalities, and how we can better recruit and retain our physicians. And what we've done is we've also formulated a a steering committee to ensure that these recommendations will be implemented. Oftentimes you'll see reports like this come out, you have recommendations made, a year or two later the recommendations are still there, but very little work has been done. So we've decided that to avoid that issue, we're going to ensure that these recommendations are implemented by having a steering committee keep everyone on task. And that has already been designed, and we were well on our way to making great progress there. So I'm going to stop there, and I'm going to hand it over to Ms. Sandra Badcock, who's going to talk to you about a little bit more about that committee and distributed medical education in general as well. So thanks very much for listening.
Thank you, Dr. Hunt. Those of you who didn't catch my name, I'm Sandra Badcock. I manage the Distributed Medical Education Office with the Faculty of Medicine. So I very quickly wanted to bring your attention to the team that Dr. Hunt alluded to. We created an interdisciplinary team from multiple organizations to specifically look at recommendation number 10, how we can engage municipalities in the physician recruitment and retention process in particular. So in August 2021, we started this committee with myself, and I'm with, again, Faculty of Medicine. We also engaged Mr. Dan Fitzgerald, who works with the Department of Health and Community Services, Dr. Hunt, who's the Assistant Dean of Distributed Medical Education, Jerona McGraw, who actually is the Program Manager for Destination Excellence, which is the strategic plan at the Faculty of Medicine, and Mr. Brad Power with Municipalities, Newfoundland and Labrador. We started with this team, of course, knowing that we were going to have to reach out to many others, but this is our core group to try to move forward with the implementation of this new toolkit. We picked this team primarily to see what each one could bring to the table. So each one of our respective offices can add something to this conversation. So with that said, I'm going to tell you a little bit about distributed medical education at Memorial. So for those of you who aren't aware, we actually send medical students and residents to 27 different sites across Newfoundland and Labrador to do components of their medical school training or their residency. We hope that this will allow us to share some knowledge with the physicians that are currently in the regions, so they have a little bit of a shared resources. We're trying to implement new technology, simulation, things that we can do to really not only improve the health and the communities of our population of Newfoundland and Labrador, but also to add to the professional development of physicians and learners across the province as well. We try to enhance our skills, again, through simulation, training, professional development, again, with physicians and learners. And of course, we try to put those learners into areas that are a little bit of an economic driver. They spend anywhere between 2 weeks and a full year in some of these communities. And they really try to integrate themselves. So we've heard stories about learners going to Port aux Basques and getting on the curling team and going out on weekends and spending their time there and really immersing themselves in the community, which is really what we're trying to accomplish in distributed medical education. So we want learners to go out there, have that first step with physician recruitment, fall in love with the community, and hopefully decide to come back there and practice, such as what Dr. Hunt did when he went back to Twillingate. So some of this will obviously work with municipalities. We do have a 2-week rotation, which is the very first one that a medical student does, where we send them out into a community. And in those 2 weeks, they actually only spend about 20% of their time in the actual clinic. The other 80%, we're trying to get them to meet with the high school, the town council, meet with public health, and learn about the things that are happening in the community that is driving the need for physicians, some of our health issues, and then bring that back to the university. And I will tell you that most people always remember the first time that we've sent them somewhere. So that could be Harbour Breton, it could be Twillingate, it could be Grand Falls, Windsor, all over the province. So this is why we thought distributed medical education might be one of the partners in the Municipality Toolkit. So we actually try to bring our students out to the communities at the very first steps in the medical school. Now, I'm going to definitely not talk about Department of Health because that is Dan's forte. I'm going to pass that on to him to talk to you.
Thanks, Sandy. And thank you, folks, for coming out at 8:30 in the morning after a long conference. It's very much appreciated. We think this is extremely important work, and you folks and the municipalities across this province are vital in advancing the initiatives that we all have with regard to physician recruitment and retention recruitment and retention of healthcare professionals in general. I know Brad mentioned this is a small room. I think he meant a small crowd because this is certainly the biggest venue I've ever spoken in. I came close once when I had to do an emergency national anthem at a kickboxing event as the MC, and we didn't have the recording on CD. So hopefully this goes better than that. So, with regard to the Department of Health and Community Services, I was thinking when I was developing these slides, it's such deep water, so much to talk about. How do you encapsulate this? So I thought, why not just touch on some key current topics that relate to physician recruitment and retention, just as some context so that you've got a sort of a high-level view of some stuff that's going on. So I'm going to start and sort of work around the circle. So obviously change is afoot with how we provide healthcare services in the province. So what that means is that service model changes need to be enhanced, and we're doing that. One example I wanted to touch on was the Family Practice Renewal Program, and specifically within that, the family practice networks and multidisciplinary teams. Back in 2016-17, government committed to investing $4.5 million per year in the Family Practice Renewal Program. And, Andrew could probably talk to that better than I could in detail, but generally for you folks, it's a number of different strategic initiatives to help improve the way we do family medicine and provide that service. Or I should say, the way we provide primary healthcare services. And the reason why I say primary healthcare services and not specifically family medicine services is multidisciplinary teams. The way physicians learn how to practice today is different than it was years ago. Specifically in family medicine, you learn how to, you train in a multidisciplinary environment, you learn how to practice in that. Same with the other health professionals that work within that multidisciplinary team. And, some of the work that goes on within the Family Practice Renewal Program is helping to build not only the experience in that, but the ability to do that. The recruitment office, many of you may be aware that there was a recent announcement that there would be funding invested to create a recruitment office for health professionals. This is an amazing investment. Without going in, I certainly don't know exactly what that will look like, but I know two elements of it that will be hugely important in creating the foundation for recruitment and retention success. And that would be creating a healthcare professional resource plan. And my colleague, Adam Churchill, is here. Adam also works with the Department of Health and the Health Workforce Planning Division, and he will be working very closely in that work. The other key piece of the recruitment office that I wanted to mention is obviously development of a healthcare resource planning strategy, or a recruitment strategy, I should say. So again, I just want to touch on those 2 points because whatever shape this takes, it'll be hugely important. I also want to talk about physician compensation. Andrew alluded to it when he spoke as something that came up and it was a clear theme in the recruitment and retention retreat, physician recruitment retention retreat held by Memorial University. And it was a fantastic and very well planned, very well delivered workshop. And I want to thank Dean Steele and folks at Memorial University for the job they did with that, because it was fantastic. But the theme came through that, we need to take a look at physician compensation. We currently have done very well with recruitment incentives, and we've invested heavily in recruitment incentives for all sorts of healthcare professionals, but in this case, physicians, and retention bonuses as well. And that was a positive theme that came through in that workshop. But we also recognized that there's a lot of work to be done to understand compensation on a deeper level. And that work's ongoing, and it's going to be extremely valuable. The health accord, everybody's very familiar with the health accord, I'm sure. We, like you, are eagerly awaiting those recommendations. And of course, the health accord's agenda is to renew the healthcare system. And those recommendations will impact physician recruitment and retention, of course, just like it will all healthcare professionals. And the last piece I want to talk about is strategic partnerships, and that's been mentioned as well. But there is no one entity that recruits physicians. It's a very long, complex process that involves so many different people. And if you think about it, it's really, all these different people that affect a physician on the trajectory from when they enter medical school to when they come out and go into practice, that affects where they want to practice. A couple of people, or a couple of the key partners that I mentioned, of course, Memorial University, Municipalities, Newfoundland and Labrador, and the College of Physicians and Surgeons of the province. So we can talk more about that in the question section, but hopefully that gives you an overview of some of the stuff that's going on. The key message I'd like to leave with you is that you can see in the center of the slide that all of this stuff is swirling around us, and sometimes it's hard to make clear sense out of what it all means. But the key message I want to deliver to you is that, we're all in it together in the middle of it. And, as I said, no one entity. So what you should take away is that you need to get involved, right? And we want you to be involved, and we will work with you as best we can to get you involved and to make the best of that, because we're better together. So I also wanted to touch on the regional health authorities. Obviously, they were a huge part of the recruitment retreat. And I thought of, what do the regional health authorities mean to municipalities? Well, in a very general sense, regional health authorities deliver your services in your communities. They also, in cooperation with Memorial University, provide the teaching opportunities in your communities. And we know that that's extremely important to where people choose to practice in the regions. They're employers, right? So some of you may even work at one, or you certainly know somebody who works at one, because they're your neighbors as well. The people who work in the regional health authorities literally live next door to you. So what does all that mean? The theme there is that the work they do happens in your communities. So what relevance does that have when it comes to physician recruitment and retention? Well, it means that you have a strategic network already, like a circulatory system in the body out through the province, that you can leverage to create partnerships for recruitment and retention. And I know that there are plenty of good examples where communities have worked with the RHAs, and specifically physician recruitment folks, to create, whether it's a welcoming environment for a new student or a new resident or a new physician, and that stuff really does have an effect. So that's all I want to say. I'm going to turn it back to Brad, and thanks again so much for being here, and look forward to our discussion.
I can honestly say after 2 days, I struggled to get up off that chair just then. Thank you, folks. That was an excellent overview of that, of the various partnerships or the various components of the partnership that we have. So naturally, my job now is to talk about what is M&L doing to support this process. I think we're all aware that we've had numerous discussions over the past couple of decades, that long, regarding the future of our healthcare system, the future of physician recruitment and retention. The challenge has been the makeup, I guess, the design of our advocacy program and how M&L works, and it has been somewhat prohibitive to us. But thankfully, a number of years ago, we changed the advocacy process. So you're all familiar with our resolution process now. We have various categories of resolutions that come to this floor to be debated and approved. There's category A, B, and C, and so on. I won't go into too much detail there. It's outlined in the convention guide, and those of you that have been around certainly understand it. But unfortunately, this issue where M&L really didn't have a direct or an ability to directly affect it always kept coming up as a category C resolution. And what that really means is that there's no doubt everyone in this room and all the members right across the province, the 275 municipalities, believe that this is extremely important. But we were limited in what we could do. It's as simple as that. However, while this was ongoing, we were still working on recruitment and retention initiatives related to newcomers in other sectors. And we had a program, and I think you're familiar with this, called Welcome NL. And this program just concluded a couple of years ago, and the focus of that was to develop community development guides, community welcoming guides and supports and tools for municipalities to encourage and maintain, skilled labor and newcomers into our community. We saw various supports set up right across Newfoundland and Labrador. We had Welcome NL community coordinators in Carbonear and Harbour Grace area. We started one. We then had one in Gander, Grand Falls, Corner Brook, and Happy Valley Goose Bay. With every intention of having more, unfortunately, we just simply ran out of time. What these groups completed, however, was the Welcome Newfoundland and Labrador guides that would help guide your town, your city, to embrace newcomers to your community. And it was specific to skilled labor and the labor shortages that we had envisioned in Outlook 2020, Outlook 2020, which was published a number of years ago. We had great success with that, direct outreach to individuals in the community. We have a number of municipalities come on board and further expand what it was that they could offer to support. But it never really went to the physician and healthcare side of things. So when we, had myself, I guess the genesis of this from M&L's perspective was that myself and our CEO, Craig Pollitt, sat and chatted with Paul Tucker and talked about where we could work together. And as we went down through the multitude of things that we could possibly do together, this one really jumped out because over the last just couple of years, it's a recurring issue at these sessions. It's a recurring issue at our advocacy sessions. It comes up during roundtables and Q&As and so on. And rightfully so. This is something that's affecting every community right across this province. So we have two components within M&L, the programs and membership component, of which I'm responsible, but then we have our advocacy and communications program, which is what my colleague Dr. Deidre Walsh is responsible for. So under the membership, we did the toolkits and the community guides for Welcome NL. We had extremely important debates and conversations around these tables about this issue. But to go back to my original point, we still had very little we could do other than talk. But then, in a separate role, before I came to M&L, I was made aware of the great work of the community advisory councils with the health authorities. And this is where many of your colleagues, whether it was through a joint council or direct outreach to your community, you came to the table to tell your situation, your individual situation, and your thoughts and suggestions on how we improve healthcare and improve physician recruitment efforts and so on. I remember having a number of representatives from Eastern Health come to the Northeast Avalon Joint Council meeting, the Conception Bay North Joint Council meeting, and the Trinity Bay Divert Mayors Association. And what that finally gave us was an avenue to directly affect change, because we were given a microphone to say our piece, to say how we could help. And of course, I always go back to, and I say our sector does this the best, the old John Kennedy quote, what can you do for your country as opposed to what your country can do for you? And many people in this room, that's our mantra is, well, what can we do? What can we do to support this? Even though it's not a direct municipal service, even though it's not something that we can control on our own, it's still extremely important to us. And I'm really glad that M&L has given me the direction as your support to come to the table with these very talented and knowledgeable individuals. It's very clear from what you've seen here that there's lots of support from all levels. We're very fortunate today to have Dr. Steele with us. This is a signal of the significance of what we're doing and how important it is that we move forward. We do anticipate that when we get a little bit further along, we'll be able to communicate out more information about what you're going to see and what a toolkit would look like. But we've already done a piece of work on this, and it's not as though we're just launching this today. This committee has been working for quite some time, and we've had some great success to date. So I'm going to give a quick overview of the work we've done. I'm going to then pass it over to Sandra to come back up and talk about the guidance that we've looked at from our partners. Then we're going to hear from Dr. Steele, and then more importantly, and I hope you've all got your coffee and you're ready to go, we need to hear from you. So over the last number of months, speaking of the committee work to date, well, first of all, I would like to commend my colleagues that are on the stage here with us, because one thing that I've found very quickly is if you want to be successful, you have to be organized. You have to bring the right people to the table, and you've got to do it regularly. And this is exactly what this team brought to the table. I think I'm the only one that's ever postponed a meeting or canceled a meeting. They've always been ready to go, and the commitment is unwavering. And I want to express that to you today, that we truly do, for this issue, for something that's so important to us and to our communities and our residents, I'm 100% confident we have the team here on this stage that will support you in supporting your community moving forward. So speaking of the work that's been done, and it's been quite extensive, the various individuals that were listed on the previous slide have all kind of taken a piece. I've looked at certain things relevant to my daily duties, and Sandra and Dan and Andrew and others have done the exact same. So we have done a literature review. We've completed this review on physician recruitment and retention in general. There was all kinds of documentation. Obviously, I'm not going to drill in on each individual thing. However, we'd be more than happy to fill you in afterwards. But this literature review kind of laid the groundwork. It laid out the first pipe for us to see what was there, how we could advance it, and how we can educate you, our members. Then we undertook a jurisdictional review to see what other regions were doing across the country. And I was pleasantly surprised to see how much information was out there and available, and how many municipalities and regions and local or regional governments and so on, and provincial governments and associations had developed various supports and tools, because obviously we're not the only jurisdiction dealing with this issue. It's not by no means unique to Newfoundland and Labrador. Then there was the engagement with the physician recruiters, who are a key component, and you've heard about them already. A survey of engagement between the physicians and recruiters and municipalities was completed. Then there was the various level of engagement at M&L. So you may recall we've had discussions at our symposiums, we've had discussions at previous conferences. We even had a presentation on the idea during our virtual conference. So it's extremely important. You've seen that, I guess, the proof is in the pudding. We say this is an issue, we continue to talk about it, and here we are today saying here's an action we're going to take to satisfy, of course, the recommendations that were in the report. And I'm going to ask that Sandy elaborate a little bit more on this one, but the medical learner feedback was an assessment of the these are the individuals, the residents that are going out into the community, and of course it was extremely important to hear from them on what their experience was, and of course them saying, here's what I need, here's the extra added level of support that we require. So there was all kinds of guidance that came from our partners. So Sandy, I'll ask you to come up next and to jump into that, and we're going to talk about what we saw right across the country. I'm going to come back shortly and talk about the collaboration. And as I said, then we're going to hear from Dr. Steele, and then we're going to get to the questions, because I think at this stage now we're enough talking. We need to hear what you have to say, because my voice will likely put you to sleep. So that's why I keep bringing Sandy and the other ones up. So Sandy, I'll get you to come up again. I'll tell you one thing, I can't wait until we get back to the world where we don't have to sanitize all these things every time we go off the podium. But it's great that we're following these rules, and I know certainly I've felt safe over the past couple of days, and I believe you have as well. We're leading the way in that regard, much like on physician recruitment for municipalities.
Thanks, Brad. I won't take up too much time because I really do want to hear from the people in the room. Just to kind of elaborate a little bit, when we do send our medical learners out into the communities, we do ask them what their feedback is. Sometimes they're looking for childcare. Sometimes they want to ask us questions about what it would look like or what school their kids would go to if they ended up settling down in a particular community. They also want to know about walking trails, places they can go, how they can immerse themselves in the community. So we actually have 10 staff with the Faculty of Medicine who are dispersed across the province and up in Labrador. And we try to get them to do little mini community profiles so that we can actually tell medical learners more about communities and not just about the clinical setting when they go out there. So just add that in. I want to very quickly talk about 3 of the toolkits from other provinces that we have actually done some work with. And there is a link to this in the slides at the end. So when you do get it, copy sent out to you, you can go in and have a look at these toolkits. However, British Columbia, Ontario, and Nova Scotia have all developed physician recruitment retention toolkits. Most of them very similar. They talk about things such as licensing. They look at ways that you can immerse the community in the process, creating almost little tiny recruitment teams that also include not only the recruiters and physicians in the area, but also members of the community, people who have like economic development backgrounds and so on, because sometimes it's not just about recruiting a physician, it's also about recruiting their family as well. One thing I found very interesting in Health Force Ontario, they actually included in their toolkit some interview questions that you could ask a potential physician, or some things that a community might want to reach out about, such as the schools, after-school programs, things that you can also ask the physician when they're coming to visit as well, to get an idea of what they're looking for. And then, of course, Nova Scotia Health, our closest colleagues, have a very robust toolkit as well. It looks at 6 different aspects and working with your communities and going on and so forth. One thing that I will highlight is each one of these toolkits looks at stakeholders the same way. They want to look with their Department of Health or their physician recruiters, their regional health authorities. They're also working with the communities, the municipalities, and all of them have communication and connections with their local medical schools or educational institutions. So I think that makes us feel like we're in a good standpoint and we're creating something similar for the province of Newfoundland and Labrador. Now I'm going to let Brad very quickly come back up, and then he's going to lead the discussion.
Thank you, Sandy. I'll just elaborate a little bit further on this, that we, through our scans and through our work, we looked at what our sister and brother organizations right across Canada do. So, of course, Federation of Municipalities and PEI and Nova Scotia and so on. And we were pleasantly surprised, I should say we were pleasantly pleased that there was a significant amount of work done. And I referenced this earlier. It's not the only jurisdiction where, supporting residents and supporting new physicians has had a focus. So we did look at guides that came out of the Federation of Prince Edward Island. We did look at NSFM. As well as rural municipalities of Alberta, and you've met some of their representatives this week, but also Ontario. Many parts of rural Ontario and their associations there have been working together on this issue. We also looked at the practice guide that was developed by Practice NL, and I encourage you to have a look at that. It's very enlightening. It's the Community Retention Toolkit. And as I said, we also looked at the Welcome NL toolkits and other sectors throughout the province that were doing recruitment and retention efforts. And further to what Sandy said, how most take the same approach in terms of the stakeholders and so on. It was that was also proven in the analysis of what our sister organizations across the province were doing too, or across the country were doing as well. So it validated the work that we're doing. Naturally, if our other organizations saw a toolkit and the development of supports for their municipalities as a wise and successful thing, then why wouldn't we look at it too? So it all lined up very, very well. So with all that said, and rather, I thought I could use my pen rather than have to touch that clicker again and have to go sanitize it before Dr. Steele comes up. So we are going to have a little discussion with you. I really encourage you to step up to the mics. There's two up here in the front of the room. We are going to have some structured questions. But before we do that, I would like to call on Dr. Steele to come up and say a few words. Before I do that, I would like to read out her biography. Dr. Margaret Steele's career spans nearly 30 years as a distinguished leader in child and adolescent psychiatry and includes experience at the Schulich School of Medicine. I think I got that right? Excellent. Faculty of Medicine and Dentistry at the University of Western Ontario, and since 2016, the Dean of the Faculty of Medicine at Memorial University. She has been a full professor of psychiatry since 2008. She has been president of the Canadian Academy of Child and Adolescent Psychiatry, president of the Association of Professors in Child and Adolescent Psychiatry in Canada, and a fellow of the Canadian Academy of Health Sciences. She is currently the chair-elect of the Association of Faculties of Medicine Canada board and will become chair in April 2022. She was appointed chair of the Association of American Medical Colleges Council of Dean's Fellowship Committee effective May 2021. Ladies and gentlemen, please give a round of applause for Dr. Margaret Steele. I did my best not to touch much of the podium. Eastern Audio will never have to clean this podium again after COVID. It'll be so clean.
Good morning, everyone, and thank you very much, Mr. Power. It's really a privilege to be here at your conference, your annual conference. I'm going to start off, I'm not going to speak long, but to tell you a little bit about the medical school and our involvement with communities, but then also tell you a little bit about how we recruit even before people are in medical school and what you could do, and then I'm really interested in the discussion. So some of you may not know, but the medical school here at Memorial has been in place about 54 years. So it was started for two main reasons. One was to recruit physicians to the province, and the second one was to elevate healthcare. Because as you know, if you have educational students, etc., you're going to ask the questions and want to know what the best practices are. So I think the medical school has done that. Can we do more? Absolutely. The medical school has 80 medical students per year, and it's a 4-year program. Of the 80 medical students, 60 are from Newfoundland and Labrador, 10 are from New Brunswick. Now, starting next year, we will not have 10 from New Brunswick, so we're looking at other opportunities for Newfoundland and Labrador students. We have 4 students from Prince Edward Island and 1 student from Nunavut, and then the other 5, 6 students are from across Canada. So we do really want to have students from Newfoundland and Labrador. Some of the things we do to try to recruit people is starting right in high school. So we have a program some of you may have heard of called MedQuest. So high school students can, in the summer for a week, either come to St. John's. This last couple of years, because of the pandemic, we've done it hybrid over virtual. But they get to meet the medical students and other health professionals and get hands-on learning on, what does it mean to give an IV or things of that nature. So it gets them excited about it. We also have a program for Indigenous high school students from across Newfoundland and Labrador, and that happens every other year, and it's called Healers of Tomorrow's Gathering. And that's a really impressive program because not only do we have our students and our high school students that are Indigenous learning together and learning about the health professions, not just medicine, but also they have the elders and other people from Indigenous communities teaching them about the Indigenous ways of healing. We also have a mini med school. So that's done now virtually. So you could take this program, but it is also available to students. So if they want to have exposure to what's happening, that's what we do. And once they get into university, there are some financial programs to help them write the MCAT, which is the exam the test you have to do prior to getting into medical school. And as you heard from Sandy, throughout the entire 4 years, they spend some time in rural communities. And then we have residency programs, particularly family medicine, which are based right out in the community. And we've heard that there are many people in the province who don't have family physicians. But I want to emphasize that, in fact, our school has done a really great job. We just looked at some recent data that 5 years after training in family medicine, 57% of our graduates stay in the province. And that's substantial. It's probably the best in the country. So even though we struggle, it's important to note that other communities also struggle. The vision of our medical school is through excellence. We will integrate education, research, and social accountability to advance the health of the people and communities we serve. So I want to emphasize the word socially accountable. So that means working with individual community people, policymakers, health authorities, and our learners to actually educate physicians where they're needed. So being socially accountable to make sure that the people get the health care they need, but also to do research that's important to our province. And for example, we have a higher rate of cardiovascular disease and other things like multiple sclerosis. So some of our research at the university is working with community members and actually studying these particular situations. So you as counselors, but also community members, if you know of anybody who has an interest in medicine, nurture that. Feel free to reach out to our admissions office, to the Faculty of Medicine, Sandy in particular, and Dr. Hunt, because we'll get them to talk to people, to understand what they need to do to get into medicine. We're very big on inviting people into the school. So if you want a tour, we have a brand new anatomy lab. It's probably the best one in the country. And we have great anatomists, and they'll do video teaching as well. So if you think that your community is interested in that, not just for the students, but also regular people in the community, that's available as well. The other thing is community engagement is so important to us. So you probably know that many of your physicians in your communities are faculty members. We actually have about 1,000 part-time faculty members across Newfoundland, Labrador, New Brunswick, and Prince Edward Island, and Nunavut, teaching our students. And as Sandy said, things like childcare, what's the activities, what's the schooling like? And if they have a spouse, which they often do, how can you as a community support them to get the spouse a job? They're going to be in that community. We had a conversation yesterday with some of our physicians here in Corner Brook, and one of them was saying she'd love to stay here, loves the job, but they can't get her husband a job, and he's currently in another province. So anything you can do with your networks is incredibly important. And we also do activities across the province. So every year I like to go across the province and meet with communities, and we meet with certain town councillors and would love invitations to be able to do that, to see how we can work more effectively together. So I'll stop there, and I really look forward to the discussion. And again, thanks for coming.
Well, thank you, Dr. Steele, and a big thank you on behalf of M&L to you for the commitment that you've expressed individually or personally. However, also a big thank you that you've allocated so many great people on your staff and within your organization to support this process. So the holding slide I have up here in front just says, how can your community engage in recruitment and retention of physicians in Newfoundland and Labrador? And it's more of a general catch-all, a theme for the questions that we're going to have come forward. But Eugene, I see would you like to ask a question before we jump in? Or would you like to just make a statement?
Oh, sorry, I thought the question period was started. It's not, is it?
Yeah, no, absolutely, certainly. But by all means, but we have some questions that we're going to ask. But by all means, feel free to ask a question. Go ahead.
Well, I'll be quick. Well, first of all, it's very positive that Dr. Hunt came back to Twinigate because, and been there 10 years now, did his training, and from there, that's a positive. That's very positive. I wish we had someone from Fogo Island that was there in their training and coming back to Fogo Island, because we have had a real big task trying to keep doctors on Fogo Island. And, Dr. Turk's been there some 10, 12 years, and he's been having a tough time with it because most of the time he's there on his own. And, 24 hours around the clock, and Dr. Turk quite often. And it's very stressful. And he have not threatened to leave, but he have said many times that he might have to leave and go elsewhere, Ontario somewhere. So I'm just wondering, because just a couple of years ago, they actually was going to force him to pay for his office space in the hospital. And I was one of the ones that went to bat on Open Line Show and wherever else I could to try to make sure that didn't happen, because he said if he had to pay that $1,500, he would leave. He would definitely leave. I was just wondering what incentives are given for these doctors. Can they have a free office space within the hospital? Because, that's one of the things that would deter them from and probably have them leave. So I was just wondering what incentives are there to keep our doctors. And you're saying, on another question was, you're saying 60 out of, or 80 out of, I'm sorry, what was the number that's in your training? Was it?
60 out of 80.
60 out of 80. So are they doctors, or are they all just medical?
Microphones there if you
are
just
they
want to.
medical students, like nurses? Or
Okay, Jay, you want to start up that mic, please? Thanks. Go ahead.
Sorry,
That's on.
I wasn't clear.
Hello, can you hear me?
Yep.
Yes, I
good.
can.
Yeah, so there's 60 students out of 80
60 out of 80.
who come from Newfoundland and Labrador.
Right.
3 of them a year are Indigenous, so we have 3 dedicated spots for Indigenous. We try to prioritize students from rural areas, but we're going to be doing a much better job at the criteria for that, and also from lower socioeconomic. So in the medical school, there are 320 medical students in total. So 240 of those would be from Newfoundland and Labrador. After their medical school, they have to train extra. So if you want to be a family physician, you have 2 more years of training. And then if you want to be a child and adolescent psychiatrist, for example, it's 6 years of training, and surgery is 5 years. So we don't have all of the specialty programs in Newfoundland and Labrador, so sometimes some of our students actually have to go on the mainland to get that extra training, and we're trying very hard to recruit them back to Newfoundland and Labrador.
So these 60 doctors is doctors, and they're from the province.
They would be
Training.
going in training to be doctors,
Doctors
yes.
from the province.
Yeah.
Okay, that's wonderful. So, the big concern is, of course, like places like Fogo Island, is what incentives are there to keep the doctors here? And, we got 90,000 plus residents in the province now without a family doctor. So we got big concerns. So we got to do whatever we can to keep our doctors. Thank you.
Eugene, it's a great point you make, but if you might just stay back, let's put it out to you. What incentives do you think will support this issue? So, of course, you said office space availability. What other suggestions might you have? And, of course, I know you've thought about this many times. Any ideas that you could put forward?
Well, like in cases like Fogo Island, with the stress that Dr. Tarek is going through, he could leave any day.
Yeah.
And we have had such a difficult time to try to get a doctor on Fogo Island. We got to try to do whatever we can to get that second doctor and make it
so
as
additional
attractive
resource, yeah.
as possible to get that second doctor and keep him. Because if you lose Dr. Tarek, you know, yes, we could get a replacement, but we haven't, it hasn't been fun trying to get a replacement doctor on football. So we got to do whatever we can, and to cherish the doctor office space within the hospital. You know, like I know doctors with private practice pay their office space, pay for their office space, yes, and you know, and there's some incentives lately, I understand, from our government to do that, right? But you know, we got to be more, make it more attractive, and that's.
Excellent. Oh, good points. Thank you very much. And thank
Can
you,
I
Doc.
just maybe, I don't know, Andrew, if you want to talk from the Central Regional Health Authority with respect to incentives in those areas. Because the other thing we heard in our recruitment and retention workshop was also business managers in their practice, because they want to practice medicine. They don't want to be hiring staff, et cetera.
Yeah, thanks. You hear me? Yes. Thanks, Margaret. No, a very good point, and I know Dr. Tarek actually very well in I guess a former capacity with the RHA and Central Health. I work with your team there in Fogo to help ensure that Dr. Tarek, yes, was going to be here to stay, and those were that was one of the points that we had to overcome with regards to overhead and things like that. Now, that's a little out of the control of the Faculty of Medicine, obviously, but certainly it is something that the RHAs look at. I'm not sure if Dan has any further insight on that as well, with regards to things like overhead or having business managers, exactly. But I think first and foremost, to address the issue with difficulty with recruitment and retaining in Fogo. I mean, we appreciate Fogo. It's a little unique given that's an island and things like that. So we have to come up with unique ideas and means by which we can actively recruit and retain our physicians. And I'm glad you put the question back to say, what can you do as a community to be able to help with that? But I think from a Faculty of Medicine perspective is to ensure that we have opportunities for our trainees to go to Fogo, to experience what practicing rural medicine in Fogo and on Fogo Island is all about. And I think working with Dr. Tarek and his team is very important in that, and ensuring that we do have opportunities from an undergraduate perspective, which is basically the first 4 years of medical school, as Dr. Steele has alluded to. During those 2-week rotations in the first and second year, to go out and experience the community, get engaged in the community, and become attracted to it, so that once the medical degree is completed, then there will be an interest to return to a place like Fogo. And likewise, in our postgraduate training, which would be for someone like Fogo, a family medicine residency program, we do have a streams program, which basically looks at an alignment of family medicine training. So training after medical school to become a family doctor takes an extra couple of years. And in this province, we have aligned our programs with the regional health authorities. So there is a stream in each one of the regional health authorities with upwards of about 6 residents per year outside of the Eastern Health Region. So in Central, for instance, we have 6 residents that join a new cohort every year. So in total, over 2 years, we have 12 residents that are actually working and learning in Central Health. Now, to date, we haven't had an opportunity to be able to have Fogo as one of the sites within Central Health, because we don't have at present a faculty member or preceptor in Fogo. But certainly that's something that we need to address, and certainly having a conversation with Dr. Tarek to be able to become a teacher and help the learners learn in Fogo, and therefore be able to really see firsthand how enjoyable life and work can be on Fogo Island. And I think that's one of the most important pieces that we can do to attract our learners and our future doctors there. I'm not sure if Dan has anything to say from
I
RHA perspective.
can add some to that too. First of all, I just want to say that I fully understand your concern. I'm from a small town as well, so I've experienced difficulties with accessing family medicine care and primary care. And my parents are still in a small town. I have a lot of family there as well. So, I don't know your specific situation in Fogo, or I should say, I do have knowledge of it, but I haven't experienced. So I don't want to say I know your specific situation, but I relate to it. With regard to incentives, I mean, we have historically put out things like bursaries and other financial incentives, and we've worked with the RHAs to do other things. specifically to incentivize financially or otherwise working in a particular place. But what we also realize is that there's this whole range of things that affect why a physician will choose your community, right? It could be the way the service is designed. It could be a whole bunch of other things. We talked about families and spouses and all these other things that make somebody stay, or all these other parts of the equation that keeps a physician in a particular place. So when we talk about we're looking at transforming things, we're looking at the broader picture as well. So I really want to focus on that. And the key thing here is to get you involved in that process such that, rather than, like, we need to work together on what the solution is rather than me to tell you what that solution is.
Excellent point, Dan. So to that end, we do have some prepared questions. I do recognize that the nutrition breaks at 10 o'clock, so we have about 11 minutes. So rather than go through each question individually, I'm going to put them up on the screen, and I would ask that you provide your feedback based on the 5 questions that are on the screen and tailor your thoughts to that. Let's keep our answers and statements to just a couple of minutes so that we can get as many people up as possible, just out of respect for our colleagues. So the five questions that we developed today, one is very generic. What's the current status in your community in relation to physician recruitment and retention? The other one is there anyone in the room here that has worked with recruitment as a town? So specific work you've done with your town. What role do you see municipalities, Newfoundland and Labrador, the department, and the Faculty of Medicine playing in this process for your community? What creative and innovative ideas, and this is a really important one, what creative and innovative ideas do you have to make your community more welcoming? And last but not least, does our conversation make sense for your municipality? So I'll ask that you have a look at these questions on the screen, you address those, and keeping a note on time, I will just kind of raise my hand if we start running out of time. Okay, so please go ahead over here.
Hi, Danielle Doyle, Tana Carboneer. I guess my comments and questions are all of that and the previous one that you had up. I find a lot of what we're doing a lot of things. Like, we've had the family medicine residents prior to COVID come out, and we did a tour within Bay Roberts, Carboneer, took them to the breweries, the restaurants, all that kind of stuff. And of course, COVID has played, some havoc in all of that. But one of the questions I had, could the distributed rural health initiative be expanded to include larger towns that have difficulty in retaining family physicians? So we're not that rural, but we don't know. There seems to be a gap in communication. Like, we have no idea when there are residents in our community, so that we could meet with them and say, okay, like, we have this excellent recreation complex. We have a college at North Atlantic here. We have a brand new K-8 school. We got an excellent high school. We have a stadium in the next community, a pool. Here's a new gym. But we have no way to connect with them. Like, we're doing what we can when we find out that there are people coming, because we have a new Welcoming Communities Committee, and we're hiring a Welcoming Communities Coordinator. And for the physicians that are coming in, say there's 2 new internists from, I think they came from Syria via South Africa. Like, we know that they're there, so like, we can meet with them and make sure that they know they're living on a street where they're going to get 300 trick-or-treaters. But like, if we don't know the residents are there in order to get them to come and stay, then that's kind of a barrier for us in order to recruit them to come and stay. And we also we were in an unfortunate situation in Carboneer, Harbour Grace area. We had a number of groups of friends who came out of medical school at the same time 30 plus years ago. So they formed a couple of clinics, and then one clinic in Harbour Grace, 3 or 4 of them retired at the same time. And then the same thing happened in Carboneer. You had 5 physicians retire within all the same amount of time. Then you didn't have any new family physicians want to move in there because they were using the old paper method for recording, medical records. Nothing was digitalized, and no one wanted to go into that space. So that's another question about, an incentive to take over existing practices and provide some support to do the medical upgrading. And I mean, we have business people in Carboneer who are willing to build buildings. If we could get some family doctors to come there, it's just like, how do we get them there? And can we increase the number of seats in the medical school for the family residency so that we are getting more family doctors come out of the program that can go back into the communities?
Thank you, Danielle. Excellent points. Anyone like to make a comment?
So thanks for that. I mean, very excellent points, yes, and absolutely very important in increasing our capacity in a place like Carbonear. Absolutely. And Carbonear has actually been a big site, I'd say, as far as distributed medical education goes, because there is multidisciplinary training happening there, not just family medicine, but certainly other specialties as well. So we've identified Carbonear as an excellent center to be able to expand even further. But one theme that comes from everything that you said is the need for improved communication amongst all the players at your site. And certainly now with our new distributed medical education office, which is brand new, we are designing and have designed these networks to ensure that this communication is now enhanced. Our academic program administrators, we have two in each of the RHAs, are integral in this regard. So they will be the ones quite responsible for looking at the schedules of what residents are coming, what medical students are coming, and communicating that information to the physicians, to the medical services department with the RHAs. And certainly I agree with you, also communicating with the municipality. So I think that's an important piece, and that is something that I'm happy that you were able to bring forward and that we can take for feedback to back to our program to ensure that that communication is enhanced so that you are quite aware when those learners show up and that you can engage with them and ensure that you're doing everything in your power to help them want to stay. The second piece, and I forget the second piece, what was that?
I think one of the questions was around residency spots and increasing residency spots. I don't know, Dan, if you want to speak to that, because it's a combination of having capacity of physicians to teach the residents, but it's also the negotiation between our Office of Postgrad with Dan, actually, around how many residency spots go to family medicine versus something else.
Yeah, first of all, I just want to comment that the work you're doing already, you're ahead of the game, and the reason why we're here is to engage all the different municipalities in that way and provide you those supports that you don't currently have. But you know, you're doing a fantastic work already, and we just want to help you with that and make it more targeted and just make it better and have success. With regard to the medical school, I mean, we expanded the medical school. We recognize that that's important, first of all, and over the last decade, we've enhanced it by about 33%. So we increased medical student seats from 60 to 80. And of course, we had to increase residency training capacity as a result of that as well. So it's already expanded quite a bit in a short time. And as Dean Steele said, that requires resources to provide the quality level of teaching required and experience in the community. Like it's not, and I'm probably not the right person to speak specifically to accreditation, but there's a very high standard for Canadian medical training. So it's not something that we can do instantly, but we do recognize that we have invested in it, and this, you know, who knows where that goes in the future, but completely recognize that that's important. I think you had also mentioned maybe about you know, the fact that you have people willing to provide space or build a facility or whatever. You know, that's really important. I want to get that message out there to all the municipalities that, you know, the places, the environments, the physical locations that physicians and other healthcare providers work in a lot of ways will need to look different than it did before. You mentioned paper-based systems and going to electronic systems. You know, there's no substitute for time to an extent in terms of getting from the old system to the new system. So it's a bit of a process, but you're exactly right. We need to get there, and any way municipalities can be involved in that process is fantastic, because there's a lot you can actually do. I know of a pharmacist who has completely redeveloped the site that he owns with a medical clinic in it, and it's basically a turnkey operation. Physicians don't have to worry about the business aspect. There's EMR, and just took that investment on himself, recognizing that, one, it's important to his business, but it's the new way of doing business for medicine. So there's that too.
I just want to make another quick comment. Sorry, I don't want to prevent other people from talking, but I think it's great that your community has been so active, and I think we can improve communication better for sure. But also we have to recognize that one of the recommendations was a way to have multidisciplinary teams, because the way physicians today practice is very different than in my day. I mean, I still practice a little bit, but it's very different. And the other thing we heard was the importance of having locums available to the community as well. So I think there's a conversation to be had with your community. Thanks.
Thank you, everyone. Okay, go ahead.
Andrew Shade, Mayor Fogel. I think when you're recruiting, you have to recruit from certain areas of the world for people to fit into your community. We've done a lot of things to fit into new doctors. We've built houses close to the hospital so that they don't have to drive in winter. All those things have been taken into consideration. And we've put per capita, I'd say we're after having, in the last 10 years, more doctors graduate in Newfoundland than anywhere else in the province. I have a niece and a nephew now training. One is in Alberta, one is in Hamilton, training. They're coming back to Newfoundland. They're not going to come to Fogo Island. I think two of them may be going to Grand Falls, somewhere like that. But we're recruiting from areas like to put in Fogo Island that don't fit there. So it's hard to keep them there. We always had a connection with Ireland and England. All our doctors came. And we had an easy time recruiting because there was always someone they came with to fit it in with the doctors. But that's not happening anymore now. Also, the system. The way doctors are getting paid. If you've got one doctor there who's taking all the customers, why is another doctor going to come and set up? Because one doctor is getting paid well, we can't even get locums anymore because it's not worth their while to come there. So why is a physician going to come to Fogo Island as a second doctor and get paid quarter what he can get in Gander or Grand Falls or Ontario or anywhere? They're not going to come. And we used to do a lot more services in our hospital. At one time, you could take out your appendix. They could born a baby. But now, depending on the month, you got to go to Grand Falls or Gander to have a baby. Great big hospitals like it's in Twinningate. Did surgeries, all kinds of surgeries. It's all gone. So now you've got an old age home, basically. So the services are not there to recruit the doctors to stay there to get the money. So we need a different pay scale for certain places like Fogo Island to keep a second doctor. That's my opinion.
Thank you, Mayor. That's a great suggestion. We are running out of time, folks, so I do ask that you keep your comments now to about a minute, please. Okay, please step up to the mic.
My name is Darlene Collins. I'm from Hare Bay. I realize that it's a problem all across the board. Like, it's not just small towns and it's big towns. I have 2 children living in Paradise, and my son is on a wait list to get a family doctor. He had to come back out to our way to see a doctor. But my thing is can we, like, I'm a visual learner as well as auditory, so I'm just going to try to paint a really quick picture. The healthcare system is the brain of the body. The doctors are the organs, the specialists. The veins are the doctors, family doctors. But unless we have cells, nothing works. And this is just a suggestion. I don't know if it makes sense to you guys or not. We have a lot of nurses at our province that are already here. Nurse practitioners. And while we're working on solutions, and I know it's going to take time to get doctors here and keep them here, can we put in more nurse practitioners to keep our communities healthy, just for a prescription, not have to go to another community 45 minutes away? You know what I mean, to see a doctor. We're filling up our hospitals, emergency rooms, for prescription, for like a ordinary thyroid issue or, something. So that was just my suggestion. I've been thinking I have more suggestions. I don't want to take time. I'd love to speak to someone further after if I can.
That would be
Thank you.
great, yeah. And I will note, excellent comments, and thank you very much. I will note that after today's session, our intention is to release a survey to municipalities that will focus on the questions that we just posed, but also to delve into more questions that we'll come up with as a result of the comments we heard today. So rest assured, we're not going to have this all finalized in a couple of weeks. This is something that's going to take a little bit of time. We want to make sure it's done right. And furthermore, we will come out and officially consult with you, our members, because the last time we did that on this and other issues was a number of years ago. So the data and information we have is very dated. So the last question, and again, I just asked you, please keep your comments short. Thank you.
Good morning. My name is Dorothy Strickland, and I'm from the town of Triton. I know that we're all in dire straits when it comes to our medical health and whatever, but I think the Green Bay in our area is one of the worst it's the worst that I've ever seen. We've got a new facility, I'll call it a health facility because it's not really a hospital, in Springdale. Most of the time we got one doctor, right? One doctor. Now, we have a clinic in the town of Triton. It's paid for by the town of Triton. Robert's Arm got a clinic, and we can't get no doctors. Even the doctors that come into Grand Falls or Springdale, lots of times now they don't want to go into the rural little places, right? To come to our clinics. Right now, we had family doctor, but he was a private doctor. Comes into our clinic too, a private one. But he's now gone into the hospital in Springdale because that's all Springdale got, right? Is really the one that got his own private clinic is gone into the hospital. And he has 3,500 patients, he's a family doctor, right? So that's 3,500 patients that not getting to see their family doctor. You know what we got to do if we want our prescriptions filled? We got to get on the phone and phone into our secretary that's in our clinic and I'll tell her that my prescription is out. They don't know if my blood pressure is on bust. They don't know if my sugar level's gone to the roof. They just automatically do out the prescription for you. Now, where have we gone to? My God, where have we gone to? Where's we all going to end up to? Because, just terrible. It's terrible. And we don't do something. And we've even, when we did have our doctors there, the doctor was like, they didn't want to drive in the winter. We even went and picked her up in the morning and we carried her back in the evening, right? And I'm sure the towns is willing to put in some money, even if you put in some money for to help pay for the rent or something. We got to do something to get the doctors there because they come there to get a little bit of training from other countries. Hey, they're only here a year or two and then they're gone. And then we got nobody. The most ones I ever seen in Springdale, right, is from other countries. They come here for a year, 2 years, 3 years, and then they're gone. But we got to do something to keep them here, right? And I'm understanding, I don't know if this is right or not, but I'm understanding a lot of medical students that's going into medical school now is not going in for family doctors. They're going in for emergency doctors.
Very good.
They don't want any family doctors. You want to go into emergency and do their time, and that's it. So I'm hoping that we're going to be able to get some more family doctors because we're going to be in need of them. We're going to be in need of all kinds of doctors. Whether it's medical, whether it's in mental illness. I got a granddaughter. She had a psychiatrist now going on 2 years. Her psychiatrist left. Come on, 2 years. Boy, something got to be done, and done soon. Or we're not going to be, we're going to be back into the days when we're going to have midwives, right?
Yep.
Oh yeah, that's coming back. If we don't, if we're going to have babies born if we got no doctors.
All right, excellent comments. Really appreciate your insight, especially from to see the variation in different areas, the variation of work that's being done. And thanks for the suggestions around transportation and rent. That's excellent comments that you're making. So, folks, we are past our time. I would like to sincerely thank Dr. Steele and my colleagues that have joined us here today. I think we've initiated a really good start to this discussion. As I noted, we will be following up in the very near future to pose more questions to you. I strongly encourage you to fill out the survey, get that information back to us, but most importantly, please make a commitment to me today that you're going to contact someone in the community right next to you and ask them to do something on this survey too. Because if we all work together and we get the ideas, as Loretta and many others have suggested, you never know. I highly doubt we're going to find a silver bullet, but at least we're going to come up with some really great concrete things that you can do to support the residents and the recruitment and retention of family physicians and in Newfoundland and Labrador.